Welcome everybody to the GEDC webinar. We will be starting in a minute, right up on the hour. Good afternoon, or good morning, or good evening, depending where you are, to everyone. My name is Dawn Milady, and I'm welcoming you to the bi-monthly webinar of the Geriatric ED Collaborative. I'm an emergency physician at the University of Toronto, where I'm also a professor of emergency medicine, and I'm joined by this distinguished group of expert panelists of an interdisciplinary nature from across the United States and Canada. Next slide, please. This webinar is the second in our series of webinars that focuses on the new CMS measures relating to age-friendly care in hospitals. This is an initiative of the American Centers for Medicare and Medicaid to implement and promote age-friendly care. It has significant interest to our international audience, as well as a valuable and probably impactful strategy for leveraging improved care for older people and driving age-friendly improvements across the healthcare system. As a reminder, the strategy is to encourage and eventually require hospitals to demonstrate, to attest to and demonstrate that they are making changes and implementing processes in each of the 5 domains that you see on the screen at the moment. Our last webinar focused on social vulnerability, and we looked particularly at dementia, so things that you could do in the geriatric emergency department or your emergency department to demonstrate that you are addressing social vulnerability. And today's webinar is going to focus on responsible medication management and things that you can do in your emergency department to help your healthcare system meet its requirements under the CMS measures. Today also is a time for celebration because we are celebrating the release of the Geriatric ED Collaborative's new toolkit, which is specifically about medication management in the emergency department. So that toolkit, which you're going to hear quite a lot about on this webinar, provides you with a lot of resources if you are wanting to make changes and improvements in how medications are managed for older patients in your emergency department. Next slide, please. We have over 300 registrants from around the world. At least 18 countries are represented. When you registered, we asked you to answer the question, what is the most problematic medication that you see in your emergency department among older adults? So I did a pretty non-scientific but experience-based look at the nearly 300 answers to that question, and I just pulled what I saw as the main themes. And that's what's on your screen at the moment. This won't surprise anybody who works in emergency departments or who works with older people, that the big hitters that are bolded there, sedatives, antipsychotics, and any psychotropic, particularly ones related to dementia. And all of the other ones are going to be mentioned throughout this webinar as well. But we would be interested to know if you want to add into the chat If there are others in your place of work that come to mind, problematic medications for older adults that you see commonly. So if you want to open the chat box and select everyone, not just hosts and panelists, but everyone, and just pop into the chat what you think of as particular bad performers in your emergency department. Next slide, please, Heather. So the Geriatric Emergency Department Collaborative envisions a world where all emergency departments provide the highest quality of care for older patients. We are a collaborative of interdisciplinary clinicians focused on the emergency department that build and distribute resources to support implementation of best practices for older people. We then also study those processes to build a research base. If you are interested in, this mission, and I assume you are if you're on this call, please, is this the next slide? Access our website and become a member of the Geriatric ED Collaborative, or follow the link that has just been put into the chat box. Next slide, please. This is our panel, whom I will introduce. I will just draw your attention to what questions do you have for our panelists. You may value the expertise that you're going to be seeing on the call today. And if you have specific questions or general questions that you want to direct to them, please do that. I would also ask you to enter the chat, open the chat box, select everyone, and let us know where you're calling in from. That's very helpful to us and interesting. And if you have any specific questions for our panelists, please let me know. We're joined today by an illustrious group of interdisciplinary colleagues. Claire Bainbridge is a clinical pharmacist at the University of California, San Francisco Health, where she covers their ICU and their level 1 accredited age-friendly ED. Mitchel Erickson is an acute care nurse practitioner, also at UCSF age-friendly ED, and is a clinical professor in the Department of Physiological Nursing. Chris Fan-Lun is a pharmacist, a Toronto colleague of mine with whom I've had the privilege of working for a long time. He's a clinical coordinator in geriatrics, palliative care, and general internal medicine at Sunnybrook Health Sciences Centre here in Toronto, as well as being a lecturer in our Faculty of Pharmacy. Liz Goldberg is an emergency physician and an associate professor in the Department of Emergency Medicine at the University of Colorado. And finally, Rachel Skains is an emergency physician and an assistant professor in the Department of Emergency Medicine at the University of Alabama at Birmingham, as well as at the Birmingham Veterans Administration Medical Center, where she's the physician champion for the geriatric ED. So with that, I think we can come out of slides, and I'm going to turn this over to Chris Fan-Lun, my colleague here. Chris, as just said, is an experienced geriatric pharmacist, and so he's the person we turned to for content when we were looking to build this toolkit about medication management. So Chris, I'd like you to give our audience an idea about how you developed the toolkit and what they're likely going to find if they access it.
Great. Thank you, Dr. Milady, for having me on. This toolkit was really designed with ED administrators and clinicians in mind to provide everyone with resources that they can use to successfully support safe medication management initiatives for older adults in the ED, as well as to meet the CMS age-friendly measure. And when you think about the age-friendly measure, it's really aligned with already age-friendly health systems and the 4Ms care. And that really resonated with me when I started building the content for this toolkit. It's intended to support the diverse and international GEDC community. And we know that not all sites are large academic centers. They may not necessarily be level 1 geriatric EDs or have abundant staff resources. And so we should also acknowledge that there are also many members outside of the US that are not necessarily impacted by the CMS measure, but there are several resources and ideas in this toolkit for the benefit of GEDC members interested in driving improvements for older adults in their EDs, but as well to strategically increase maybe the number of geriatric-focused care processes to help move up their GEDA accreditation level. So I like to think of this toolkit as like a big sundae with several layers into it. So let's dive in. So the first couple sections are related to making the case for pharmacy resources and staffing in the geriatric ED. We share a blog on the importance of medication reconciliation across transitions of care, especially admission, but also discharge, as well as the role that pharmacists can play in addressing medication safety issues in older patients. Now, to help staff as well as administrators, we actually provide justification for implementing a medication management quality improvement program that is supported by pharmacists as part of the age-friendly ED team. We even provide a very brief slide deck for the C-suite executive leadership team at your hospitals that highlight, pharmacy involvement in the ED that can actually significantly reduce medication discrepancies, prevent adverse drug events, minimize the use of potential inappropriate medications, and improve patient outcomes, especially when it comes to medication safety. The goal is that people should know that when you invest in dedicated pharmacy resources, it's almost like a demonstrable return on investment. Getting high accuracy medication histories in the ED at the beginning from a pharmacist or a pharmacy technician can prevent needless admissions and readmissions and improve patient care, especially for our high-risk older patients. It leads to cost savings, workflow efficiencies for nurses and physicians, as well as promoting interprofessional relationships and improves, patient job or pharmacist job satisfaction. Another big component of the toolkit, obviously, is education. And we have two resources that are worthwhile for members to review. The first is an online Geri EM course focused on understanding physiological changes with aging, how it affects medication prescribing in older adults, considerations for drug and dose selection, polypharmacy recognition and management, as well as high-risk meds and drug interactions. And then the second is a GemCast podcast with Drs. Casey and Dr. Shenvi that aired in the fall last year. And they discuss some really great strategies for ED physicians and their approach to deprescribing using case examples and keeping primary care at the top of mind. The next section, which is a big bulk of the toolkit, is about integrating responsible medication management into care processes. We encourage sites to leverage pharmacy support that will help them not only meet the CMS age-friendly measure, but again, as I mentioned, it can also strategically help them advance their level of GEDA accreditation. As you know, you need more care processes as you go up in levels. So we have 4 relevant topics in this section, the first being devoted to med reconciliation and comprehensive medication review. We try to distinguish among some key medication safety processes that enhance the care for older patients, beginning with what we call the best possible medication history, which is the foundational step. It's a systematic process involving the patient, their caregivers, and it's cross-referenced with at least one or more reliable sources of information. The goal is to obtain a complete and accurate list of all the medications the patient is taking that all the clinicians can use for review, assessment, potentially deprescribing. And both pharmacists and pharmacy technicians can play complementary roles in this process. The second part, obviously, is med reconciliation. Again, this is not the most intuitive term and everyone gets confused by it, but it's a process that builds upon the best possible medication history to identify and resolve discrepancies between a patient's actual medication use and medication orders at transitions of care. It ensures that if there are any medications that are added, there are dose changes or reductions, if medications are stopped intentionally, that the documentation is done and it's appropriate and carried to the next transitions of care and those providers to receive. And this is a process that you should actually have in place especially when patients are boarding in the ED as well. waiting for admission. It's an important GEDA care process. And we also want to emphasize that not every older adult requires admission to hospital. And so when that older person gets discharged out of the ED, they're also particularly vulnerable to unintentional medication errors. And that's why medication reconciliation is really important for those older adult patients getting discharged as well. The comprehensive medication review is the third part. And this is more of an in-depth evaluation of a patient's entire medication regimen. Applying knowledge of geriatric principles and pharmacology allows one to select appropriate drugs and dosages, considering the patient's acute diagnoses, their chronic conditions, other medications that they take, as well as their functional status and their goals of care. One has to recognize that high-risk medications in older adults and how they can be actually safely used or avoided. The other thing is that during a medication review, other things that get done are looking at drug interactions, looking for therapeutic duplications, presence of inappropriate medications, but as well alignment with clinical goals, such as in the 4Ms, what matters most to patients and family members. The med review is really valuable to help clinicians optimize as well as potentially deprescribe medications.
Chris, I just have a question for you on that topic. If somebody on the webinar, for example, didn't have a pharmacist in their smaller emergency department, for example, is what in the toolkit could they use to do the kind of thing you're talking about, getting a better medication record? Is there stuff in the toolkit that would help them?
Yeah, that's a good question. And so we know that, you may not have adequate pharmacy resources. And so we actually want people to consider some practical tips and considerations for structural changes, such as, having policies and procedures in place that support medication reconciliation. Maybe it's not done by a pharmacy or pharmacist or pharmacy technician, but it's a way to sort of get to trying to provide high value information and assigning people that could potentially contribute to either history taking and how to do a med rec, and triaging the patients that would benefit from them, knowing that, again, may not happen with all patients, and we have to be realistic. So in terms of that, we also say we also include examples of triage trigger examples. So sites can use, one or more triggers depending on your team, resources, and patient populations to, trigger a pharmacy review. If it's very limited in the ED, it may not be dedicated. And so there's ways to sort of consult pharmacy. And the procedure can actually detail how one identifies potentially inappropriate medications based on validated tools like Beer's criteria or GEMS RX, which we know some of our panelists are going to talk about. And then the third aspect, which is also incorporated in this process, is clinical decision support. We know that for EDs with CPOE or electronic medical record systems, they can incorporate them, the support into ordering panels like the Equipped initiative that Liz is going to be talking about more. But I want to say that we have examples of Equipped in the toolkit, especially examples such as the pain management ordering panel, which also incorporates education, discharge medication order set design to promote safer prescribing, and potential alternatives to those inappropriate medications that get some older adults into trouble. Some tips we provide are to use some brief but practical precautions with education, pharmacology, and pharmacokinetic considerations for older adults in the panels, rather than order alerts or pop-ups that interrupt workflow or contribute to alert fatigue to the ED user.
Right, Chris, I'm just going to ask another question which has come in from the chat and relates to this. What about tools around discharge? So one of our audience is wondering about a printout or a structure or a template for older patients before being discharged. Is there any guidance available?
Yeah, we don't have that particular information in the toolkit, but I do know that sometimes there may be brief letters that you may want to send to the receiving care providers in the community about, what are some of the concerns? And I think from the GEMcast podcast, Dr. Shensby and Casey's talked about this in a little bit much greater detail about how you can actually just liaise with primary care where it may not be make the most sense to stop something in the ED, but it would be highlighting to back to primary care. There may be an adverse drug event that could be related to medications that the person is taking. And that can be, the sort of starting point to get the conversation going for follow-up and for potential for deprescribing. Now, I do want to get to the last part of the toolkit, and how we meet the age-friendly measures. We do have lists of identifying high-risk medications in older adults. We've adapted a bit of work by Edward Marcantonio, who is a geriatrician and leader in delirium research. We have some of the AGS, or American Geriatric Society, Beers criteria, as well as the GEMS-RX, the Geriatric Emergency Management Safety Recommendations by our fellow panelist, Dr. Skains. Now, I mentioned this toolkit is kind of like a sundae, and the sort of the cherry on the top that I would like to say and mention is the example of an order set that's really aligned with the 4Ms and the CMS measure, as well as GEDA accreditation. Order sets for common geriatric presentations should include particular attention to geriatric appropriate medication use and dosing and management. And so, as an example, we have a delirium management and prevention order set that sites can hopefully leverage. And another aspect to consider is that this could actually be built into existing order sets, and it doesn't have to be a standalone order set. And so that's about it.
That's quite a lot of stuff. Now, just to address some of the questions in the chat, people were wondering if they were supposed to be seeing a slide deck. No, Heather's going to repost the link to the toolkit. Chris was giving you a very brief and rapid review of everything that's in it. And it's not practical to going through on a set of slides. So I would urge you, if you're interested in what Chris just said, and there's a lot of valuable resources there, to either now or shortly visit the toolkit that he's prepared. I was impressed, Chris, by how practical this is. Like, you've even included like a tool, a slide deck that people could put together if they're trying to make a pitch for increased funding for a pharmacist. Is that right?
Yeah, that's right. And so, maybe you're aiming for a pharmacist, but it's hard to get those resources. But, it's good to have that messaging there. What are the downstream effects to patients and specifically to the ED?
Mm-hmm. So I'll thanks, Chris, for all the work that you've done over the year leading up to developing publishing this toolkit. And thanks for the quick rundown on what people are going to find in it. I'm going to now move on to our interdisciplinary group of experts, starting with Dr. Liz Goldberg. I know that you, Liz, have had a long involvement with medication management, medication safety, education around it, research around it. So could you tell us about some of your activities and what you've learned, including that excellent question from one of our audience about what do physicians think about this topic? Big ask.
Great to be here, and Chris, excellent introduction. As a reminder, I'm an emergency physician. I practice here in Colorado, but I've practiced in other states previously. We think a lot about how do we use ED pharmacists and best help them succeed in the emergency department setting. And I'll just give an example from the falls prevention research that we've done. In 2017, when we first started our NIH-funded study to prevent recurrent ED visits for falls among emergency department patients, we had to make some decisions about what fall risk factors can we address in the emergency department. And we knew for fall specifically, patients come in with a long list of reasons for why they fell. But one of the most important reasons for falls is because they're on medication that increase fall risk. And we had just at that time at our level 1 trauma center staffed our first ED pharmacist from 7 a.m. to 3 p.m. So I knew that we had that resource available, but there were a lot of protocols for how to involve ED pharmacists in patient care in the emergency department. And so I'm going to share one model that we use successfully. Again, our research was a clinical trial. It was focused on preventing patients that came in with a fall to the emergency department from coming back again for a recurrent visit for a fall. And we did successfully reduce recurrent ED visits for falls by 66%, which was significant. And there were 2 interventions that were involved in that. The one involving pharmacists was that pharmacists met at the bedside with ED patients. They went over their medications and identified those that increase fall risk. I'll give an example. Flexeril was mentioned earlier. We know that that has psychoactive effects and anticholinergic effects and can increase fall risk. So in that case, the pharmacist would meet with the patient. They'd ask, why are you using the Flexeril? How often are you using it? Are you open to changing the way you use it? And if there was buy-in from the patient, then they would write a brief consultation note and say, we discussed Flexeril. The patient isn't actually benefiting from this medication. It's only making them drowsy and it's not improving their muscle spasms. So we discussed that as a PRN medication, they may not want to continue using that. And then at the end of our consult note, we put that medication changes are really up to the primary care physician, that this was a collaborative conversation with the patient, and ultimately medication changes should be made in consultation with that primary care doctor. And so then the pharmacist would route their note to the primary care doctor. And our hope was that by having that conversation, initiating that conversation in the ED, the patient would also remember that and bring that back to their next primary care doctor visit and say, hey, we discussed this medication wasn't really effective for me, was maybe increasing my fall risk. Do you think it's reasonable for me to stop this medication? Now, that may be easier for a PRN medication or medication you take as needed, and maybe more difficult for someone that is on a daily dose of a benzodiazepine, for instance. But the whole purpose of our intervention was to identify just 1 to 3 medications that could be contributing to fall risk, initiate that very brief 10 to 20 minute conversation in the emergency department with that patient, and then really minimally disrupt emergency department care, not require the ED physician to make those changes definitively because maybe the ED physician doesn't have that necessary context, but provide a warm handoff then to the primary care doctor that, hey, we discussed this, but we also discussed with the patient, don't make any changes without having that consultation discussion with you, because we understand there might be reasons why, even though we see it as potentially inappropriate or we see it as increasing fall risk, that patient actually needs to continue that medication.
I'm just going to jump in for a second. Just remind me, so what would trigger that particular intervention? Because it's a great...
Yes, so that's a really important conversation. Obviously, there's not enough pharmacists to go around for every emergency department patient. So you have to think carefully, as I'm staffing the emergency department, who are the most high-risk patients that those pharmacists should get involved in? And in our case, we're trying to prevent falls. So any older adult, 65 and older, that comes to the emergency department for a fall and is likely to be discharged after that ED visit, that's where we think we have an opportunity to intervene. Patients that were going to be admitted that could be seen by, the inpatient pharmacist, that was a different population, and patients not coming for falls weren't relevant to our study.
And we have a very practical question in the chat relating to this. Whose responsibility is it to get the recommendations to the PCP?
So in our study design, that was upon the pharmacist to route that note to the primary care doctor. And obviously a lot of things need to happen for that to occur successfully. A primary care physician actually needs to exist. Some of our ED patients don't have a primary care doctor. B, that person actually needs to be listed in our electronic health record so that routing can occur successfully. And C, the patient actually has to agree to being involved in this conversation and having that be routed. So it sounds simple. It's not that simple. I'm going to put a link into the chat of our study protocol, and what that pharmacist consult note looked like, so folks can see how we did that. I did want to segue to a second intervention that we did in our emergency department called Equipped. This intervention is called Enhancing the Quality of Prescribing Practices for patients discharged from the emergency department. And it was founded by Melissa Stevens and Dr. Camille Vaughn. And the idea was, can we help ED docs and other ED prescribers make the right decisions before they discharge a patient from the ED in terms of not adding a medication that's potentially inappropriate for that older adult. And that intervention had 3 different arms. It involved educating ED clinicians, because not every ED clinician during their residency gets a lot of training on how to do medication management in the older adults. So we gave grand rounds actually around the whole state to help with that education piece. We also had a order set. So ED clinicians, if they wanted to discharge a patient that was older and they had a pain complaint, they could open the geriatric pain order set, and they could see which medications are more appropriate for older adults. And then there was also a peer benchmarking component where each month our ED prescribers would get a list of the medications they prescribed that were potentially inappropriate and how they kind of measured up against their colleagues. And we did find, doing this Equipped intervention in our ED, that we were able to significantly reduce potentially inappropriate prescribing. One thing I'll note with that is there's still discussion, and Dr. Skains is an expert in this, so I'm going to let her talk about that in terms of what is potentially inappropriate to prescribe to older adults. In the Equipped study, we use the AGS Beers criteria for potentially inappropriate medications, but we know that some of those medications may be needed for ED patients, and we probably need our own list of what is inappropriate or not, or potentially inappropriate in the ED setting. And so I'm going to let Dr. Skains talk about that, but suffice to say, I think our experience running our research lab and focusing on medication management in older adults is that we can do things in the emergency department to reduce potentially inappropriate medications among patients, and also help them reduce fall risk by thinking about how do we best utilize our ED pharmacists as an excellent resource to help us with geriatric prescribing.
Thanks, Liz. Several great ideas. I mean, I think those people who are familiar with Equipped, and if you're not, please access the link, have been struck by what a practical, effective strategy it is to make small changes in physician prescribing patterns. And this goes back to the question we had: are physicians interested? Yes, we are interested in providing better care, and it's very helpful to have practical strategies for doing so. So thanks a lot, Liz. And I'm going to move on to our colleague, Dr. Skains. You work in a slightly different system, the Veterans Administration system. How have you changed things in your EDs to improve medication management?
Yes, thank you. I'm so happy to be here, and I will be talking and touching on points that both Liz and Chris have mentioned earlier as well. I did put together a few slides just to facilitate the conversation, and so I did have one on the flow diagram for the project that we implemented at our Birmingham VA that I'll be talking about first. So as part of our level 3 geriatric ED accreditation in our Birmingham VA, we implemented a geriatric medication safety initiative leveraging our ED clinical pharmacists. So because older adults are at high risk for adverse drug events in polypharmacy, the purpose was to establish a process for medication review, identify risk associated with medication compliance, and then provide individualized recommendation for safe medication prescribing in conjunction with an ED pharmacist. So last year, the National VA Geriatric ED Core Committee developed a national pharmacy note template that was called the ED Geriatrics AGS Beers Medication Review. And at our site, veterans age 75 or older presenting to the ED are screened for polypharmacy and high-risk medication through the ISAR. So the ISAR is the Identification of Seniors at Risk screening tool, and it's utilized in triage by our triage nurses to identify a high-risk subgroup of older veterans who would benefit further from a medication safety assessment and intervention by our ED pharmacist. If the ISAR is positive, the triage nurse then places a geriatric ED pharmacy consult order where the ED pharmacist complete the AGS medication review note, which includes reviewing patients' home medications to identify AGS Beers, PIMS, and then providing an intervention with recommendation for alternative medications, cessation, or discontinuation. If the patient is discharged, this note is forwarded to the primary care provider, and if the patient's admitted, this note is forwarded to the inpatient team. And so I'll stop there as part of our geriatric Birmingham VA initiative.
Great. So I am interested because this does turn on the ED triage nurse intervening. And I think anybody who works in an emergency department, and there's lots of people here who do, know that loading yet one more even small task onto the triage nurse can be challenging. How did you address that?
So we were very fortunate that we had a lot of buy-in from our department. So when we were developing the protocol and the standard of procedure, the SOP for the Birmingham VA, we do have an ED nurse champion, and we also had pharmacists, the department chair, the charge nurses, all the nurses that do triage in the conversation when we were developing the initiative. And I think that the buy-in that we got and the fact that the ISAR has been embedded into the triage note has really facilitated how easy it is and how quick the screening can be and how beneficial this can be for the patients. And the fact that we had ED pharmacists already embedded into our ED, that was really helped justify their time spent there and the benefit that it can provide to the patients.
Thanks. Yeah, so I mean, it's interesting that you already have the ISAR as part of your triage processes. I think more and more we are seeing that lots of EDs around the world have some sort of screening tool for older people, ISAR, TRIST, frailty screening tools. So it sounds like you just chose to use that, and presumably there was a cutoff. Well, you said great scores greater than 3. Those people, so it didn't really add any extra work to the triage nurse's job.
Other than just placing the order if it was positive, it did not add any additional burden to their triage process.
Okay. Sorry if I interrupted you.
I just wanted to then talk more about Equipped and how we've integrated another tool, a clinical decision support tool, both at our UAB, but also our Birmingham VA, called the GEMS RX. So the Birmingham VA was one of the original sites for Equipped, and then we have now expanded it to the University of Alabama at Birmingham. And as part of the Equipped Quality Improvement Initiative, we've incorporated the Geriatric Emergency Medication Safety Recommendations list, or what we're calling the GEMS RX list, into our clinical decision support for our ED providers. So the GEMS RX was published in Annals of EM, and it's the first expert consensus-based list of high-risk prescriptions specifically for older ED patients who are going to be discharged. It was used to update a novel geriatric prescription safety quality measure that was developed by ASAP for use for emergency clinicians participating in MIPS, which is the Merit-Based Incentive Payment System. The GEMS RX list aligns well with both Equipped, but also the AGS Beers list, and it includes 8 high-risk medication classes to avoid prescribing to older adults at ED discharge. And so you can see here, these are the 8 medication classes. And not only do we provide the 8 medication classes, but we provide on a list of alternatives to use for different indications, and then also an exclusion list, which would be reasonable indication to prescribe these medications at ED discharge. As another side note, the AGS is also working with all of their specialty interest groups, or their SIGs, to develop Beers criteria lists that are specific to each specialty. And so emergency medicine is also participating in that to create a more EM-specific Beers list.
I would make the observation that just under the title therapeutic class that we see on our screen, that list of 8 classes almost completely maps on to the very first quiz that we did, asking people around the world what are the most problematic medications that they're seeing. So it seems like you're on the right track, and it has face validity clinically.
And then the final thing I wanted to plug in, and it's on my next slide, is that in the US, we have in 2014, multiple societies created the Geriatric ED guidelines, and we now have different working groups in different domains, including a medication safety or medication management domain, to update these guidelines as they are now almost 10 years old. So as part of the medication safety working group, we recently published 2 different systematic reviews and meta-analyses, one of which was on ED-based geriatric medication safety programs. And it really emphasizes the toolkit that was just published in GEDC, the medication management tool list that Chris was talking about, and that we found in our systematic review and meta-analysis that multidisciplinary teams, including clinical pharmacists and or geriatricians, was associated with improved PIM deprescribing, and also computerized clinical decision support systems like CPOE or order sets, along or in combination with ED clinician education, was associated with enhanced geriatric ordering and prescribing practices. So we're currently in the process of using the GRADE approach to formally make recommendations to update the Geriatric ED Guidelines 2.0. But I just wanted to emphasize that that this is in conjunction with the toolkit, kind of a flow diagram that can be very helpful in how all of these multidisciplinary teams can interact to improve medication safety in older adults in the ED.
Thanks, Rachel. Can you just as a last comment, can you just remind us of the 8 heavy hitters on the GEMS RX list? Do you have them off, or can we go back to that screen for a moment just to review there?
Yeah, so this list was developed using a modified Delphi process with multidisciplinary experts, including emergency physicians, pharmacists, quality improvement, or quality measure experts. And we started, the initial base of the list was the AGS beers list in its entirety and its full comprehension, in addition to a literature search review. And then we had 3 rounds where we narrowed the list down to what we thought was most applicable for emergency medicine for older adults at discharge. So these are discharge prescriptions to avoid. What are the highest risks to avoid, and weighing both the risks and the benefits. So you can see there are some medication classes on here, like sulfonylureas, that are probably not prescribed very frequently at discharge for older adults, but we thought that the risk of prescribing it was high enough that we needed to include it on the list versus the benefits, particularly since there's a lot of better alternatives and safer alternatives out there.
Good. Okay. Thanks a lot for that, Rachel. The GEMS RX has just appeared in your chat box if you want to link directly to it. So I think we can go out of slides at this point and head to San Francisco, where our 2 interdisciplinary colleagues are waiting to hear from Claire Bainbridge, an ED pharmacist, and Mitchel Erickson, a nurse practitioner in their level 1 age-friendly ED. So can you tell us about some of the changes that you've made there?
Sure. Well, good afternoon, morning, evening, wherever you are. So I just want it to be helpful to start with where we were and where we are now. So where we started was that medication reconciliation or medication review was fairly negligible by ED providers and the nurses within the ED clinical setting. And so we struggled to improve. And when we embarked on our level 1 accreditation, of course, medication management and reconciliation had to be part of one of the policies that we would address as an age-friendly ED. And there were also some other influences which had to do with legislation. But where we started with addressing medication reconciliation across the whole health system was really in the emergency department, targeting high-risk patients, which we considered older adults a high-risk population. So that's where we started. And that involved incorporating pharmacy technicians to do multi-source verification around medication history in terms to get that accuracy that we were seeking. And because we don't know whether patients will be discharged or admitted, where those opportunities to tackle those challenges occur later. The other thing that Claire and I did were involved in some research around medication self-management challenges, because we felt that reconciliation itself wasn't just about an accurate history of what the patient was actually taking or prescribed, but also involved older adults' challenges to how they acquired or how they managed the modalities of administration of those medications. Because it's one thing to prescribe, but it's another thing to enhance the ability of patients to be able to acquire and take those medications. I'm going to let Claire then now talk about what her role is on our service and how we communicate with providers and the health system more broadly.
Mitch, just before you hand over to Claire,
Yeah.
just give an example of what you mean by, barriers or problems for people accessing medications.
Yeah, so I'll put it in the chat. There's a link to the published research, but essentially we were looking at different domains of challenges. So domains such as knowing what the medication was for, were they able to swallow pills as they aged? Were they able to actually access the containers pills came in? Or could they manipulate the modality of administration, whether it was oral or injectable or an inhaler? Or could they afford to purchase or pay the copay for the medications we were prescribing? And could we use alternatives that were more affordable to them? And so there were a lot of issues around older adults, especially a common one, which was evolving arthritis, for example, and their ability to manage those modalities of administration.
That's a fantastic point to make, because I think it's something that physicians, when writing the prescription, often never think about. Anyway, over to you, Claire.
Great, thank you. So my role as the age-friendly emergency department pharmacist, what I'm doing is really reviewing the pharmacy technicians' BPMHs. And just one plug of something that really has worked well for us, or something that we've noticed, is really that time and effort that you spend training your pharmacy technicians really pays off. So I think a lot of effort up front to really, spend that time to have a good training program. We, in compliance with some of that legislation Mitch was referring to, we also have a regular audit program to ensure that our techs are maintaining their skills as well. So we do have, I believe, very high quality BPMHs done by our pharmacy techs, and a pretty great workflow there. So then what I'm doing is I'm reviewing their work, making changes to the med list to make sure it's accurate, based on the information that they've gathered, and other information that I'm taking from the chart. After that, I'm then writing a clinical pharmacist note in our chart, where I'm reviewing, again, potentially inappropriate medications and kind of a variety of things that also probably satisfy that domain 2 of the CMS requirements. So I'm looking at what medications could be contributing to why the patient is presenting to the ED. I'm using the American Geriatric Society Beers criteria to see if there's any potentially inappropriate meds that way. I'm looking at renal dose adjustments, CNS depressants, anticholinergics, vaccination status, as well as DDIs and other duplications. And then this note gets posted in the chart. Any urgent medication changes, for example, I think this was brought up earlier. If somebody is presenting with hypoglycemia, I see on their med list that they're taking a sulfonylurea, they have an overly controlled A1C. My recommendation is going to be, coming off of this sulfonylurea and preventing further admissions due to a hypoglycemic event. So those recommendations I'm going to be communicating to the ED team, or if the patient has already been admitted, to the admitting team. My note is also routed to the primary care physician, so that, because again, we do recognize that not all of these changes that we're potentially, or recommendations that we're making, are necessarily appropriate to be changed right there in the ED. It needs close follow-up, PCP monitoring, potentially a taper to avoid, a discontinuation syndrome. So those are just kind of some of my workflow, as well as how I'm communicating recommendations and who I'm communicating these recommendations to.
There is a question for you, Claire, specifically in the chat, and that's around education for your med techs. Pharmacists are obviously kind of well tuned to all of these things. What kind of education do you provide for medication technicians?
That's a great question. We have a pretty extensive training program, so the duration of training and orientation does last quite long, but we do find that the return on investment really pays off there. I mentioned we have regular audits, as well as we have regular Feedback Friday sessions for our techs to keep up with, changes, hints, things that they may come across multiple times to help make sure they're staying well informed about different medications and whatnot like that. They have to, throughout the audit, we're looking at a subset of their BP meaches that they've done, making sure that they're following our policies and procedures. And again, I think those are kind of the main things that we're doing. But like I mentioned, that feedback early on, and the effort you put in the beginning, I think is really critical to kind of shaping how, excellent and stellar these texts can be.
And I'll just point out that the free open access accredited module on geriatric medication management that Chris mentioned earlier, and that is available on the GEDC website, it would be extremely suitable for a medication technician. Back to you, Mitchel, or are you wrapped up?
No, I would just point out that, we don't have 100% pharmacy coverage on our age-friendly ED service. There is always a ED pharmacist, but they are often distracted by the many responsibilities they have to the remainder of the emergency department. So our NP providers on the service also do medication history review to make sure that we don't identify something that may have resulted in the patient presenting to the emergency department. And in some cases, Claire and I have found things that are immediate, and we will immediately contact the primary care provider and say, hey, you prescribed this medication, but so did this other specialist, and so they're in conflict with each other. We have to choose one or neither of you to prescribe this medication. What do you need to do? So sometimes it is in real time. I wanted to point out something about the reduction of potentially high-risk medications. So we focused on the reduction of benzodiazepine use specifically in our ED around a PDSA cycle. And we started at a baseline of about 2.4% of older adults who are being prescribed benzodiazepines in the ED. And we were able to reduce that down to 1.3 through a fairly straightforward sort of cultural shift in education. And then to complement that, we embarked on something called Code DICE, which refers to describe, investigate, create, and evaluate. And what this does is a preemptive kind of assessment for at-risk patients, and where we focus on non-pharmacologic interventions in patients. Claire can share an example of this, but the idea is that we pull together the interdisciplinary team in advance of something actually evolving into a difficult situation in the ED. Claire, you can describe your example.
Yeah, and I think, one great feature of this, it's a multidisciplinary approach. And what we have found as an example is when a patient has been called for a code DICE is, we're very quick to jump to medication and medical restraints. And in order to avoid that, having this multidisciplinary approach to really investigate what is the cause of this patient's experiencing distress and whatnot. We've had some great success stories, and an example of that is, this non-English speaking patient, very agitated, pulling at lines and whatnot, really wanting to leave after kind of some communication amongst the whole group. And in addition to the interpreter, we learned that this patient really just needed to use the restroom. And that was, we avoided giving medical restraints by simply ensuring that they had access to using the restroom. And this is just one of many situations where a code dice approach can avoid using medical restraints for our patients experiencing distressing behaviors.
And the last thing I'll mention that Erin already put a link to in the chat, and that was, we have introduced another non-pharmacologic intervention into our service, which is triggered commonly by the code dice, or at least patients who are identified at risk because they come in with dementia or already have established delirium. And we are using music intervention that is tailored specifically to that patient's known interests. And we use portable devices to do this, with or without headsets, depending on where they are. And we have had a considerable amount of success working with our neurology colleagues, sort of researching the outcomes in this space. But using music to avoid restraint and medication intervention for behavioral expression that's not consistent with safety in the emergency department. So it's a new and evolving intervention, and it seems to be very successful to date.
So I mean, that's a fantastic example of a rather extreme non-pharmacological thing, but in fact it isn't all that extreme. Just letting somebody to listen to music that they want to listen to seems like a pretty easy way to get somebody to chill a bit. Practically speaking, who's responsible for that? Like, who says get the headset?
So we, because our consult service does a lot of screening around delirium and dementia, and of course, family and caregivers are involved, what we do is we preemptively introduce this intervention where we suspect that there's this possibility. So our NP providers who are acting as the consultants for these patients will bring these devices into the emergency department. And headsets are used when they're in the hallway. If they're in a room, we can just use it, in the room in general without a headset. And, some of the examples are patients who are trying to leave because they're disoriented, and we start playing music that catches their attention because we ask the family, like, what kind of music does she like? And all of a sudden the patient is like distracted about why they were trying to leave, and they're sort of reoriented back to their room, and no restraint was used, no medication was used. So our MP providers do that.
Sounds fantastic. If nothing else comes out of this webinar, I hope that all over the world, people with BPSD are going to be listening to the Beach Boys. So as we come around to the top of the hour, Aaron, any last questions that you want to draw to our attention?
Yeah, there was one, Mary Kim Lubinsky brings up a great point of being able, great example of being able to use music, and she has Bing Crosby. I remember a patient with dementia. I put YouTube polka. We listened to polka concerts for hours. So great. Music is such a wonderful piece. But yeah, but an actual question is experience, you're developing all these resources, you have these into actually order sets. One of the things, there's the concept you can lead a horse to water, but are you going to make them drink? What were some of the approaches working with your providers to have them use those specific order sets versus the normal ones that they would use day in and day out?
I can speak for our institution. I mean, one of the things was we made them more accessible. So they're front and center. So they have order set lists, and this order set just sits in that list. So it's literally one click rather than picking and choosing elements of a variety of different interventions that a provider might use. There's like one-stop shopping at the grocery store. You just click on one, it's a geriatric ED order set, and they can click on it, and all the possibilities that meet all of the level 1 accreditation policy requirements are addressed in one click.
Good. So we are now 2 minutes away from the hour. Heather, could I ask you to pop us back into the slides, because we have asked all of our panelists to prepare just some take-home points, which we won't go through here, but this will highlight that all of these slides, the chat, a resource list, and the presentation itself will be available on the GEDC website in a day or two. Here are some of the resources, including the toolkit developed by Chris. Next slide. Have we got through the... could you just click back a few so that people can see the take-home points? Yeah, so each of our presenters has created some take-home points, which we won't go through here. So now that I've asked you to do that, Heather, please click forward. That's the toolkit resources. GEDC is available, so please contact us if you want specific tapered guidance around implementation. Next slide, please. Our next webinar will be in October, and that will be continuing our CMS series, and that is the 5th of the 5 measures, what matters, so how you can elicit patient healthcare goals in the emergency department as well. Next slide, please. I've talked about the GEDC. I hope you are enticed to coming to our website to join us. Next slide is the most important one. We want to thank the John A. Hartford Foundation and the West Health Institute for their generous ongoing support that allows us to do the work that we think is so valuable. And finally, in closing, I would like to say a special thanks to all of our panelists for devoting quite a lot of time to prepare for this and to be available to us today. I hope that you've taken away a lot of, that the audience has taken away a lot of valuable pointers. And we will look forward to seeing you all again on the next GEDC webinar. Bye, everybody.
Thank you.